Yes, like Kathleen said, my name is Mackenzie, this is Hannah, and we are both presenting on adolescents and young adults with perinatally-acquired HIV. We both worked with Dr. Cynthia Fair, who's wonderful, and have similar projects, so we're going to kind of start together and then break off into our separate studies, which they are totally separate, but they're similar definitions, similar concept, and similar methods. So first we'll give you a brief overview of PHIV, this big word, perinatally-acquired HIV, and then go off into our similar methods, and then I'll talk about my study for a little, and Hannah will outline hers.
So first we're going to talk a little bit about how HIV has changed over the years. So before the 1990s, HIV was a deadly disease. However, with the introduction of antiretroviral treatment, a very important medication, it has become a chronic and manageable disease. There are many people living just very average lives in the United States that have HIV. However, before the introduction of this medication, there were people that had HIV that were having babies, and something called mother-to-child transmission is a way that one can contract HIV from your mother at birth. So there were babies being born with HIV in the 90s who, with the help of antiretroviral treatment, have now survived until adolescence. And so that is kind of how we get to our project of perinatally-acquired HIV. So this new population, so when these babies were born with HIV, with perinatally-acquired HIV, it was not clear whether they were going to live to adolescence. However, now there are 10,800 people in the US that have PHIV and are living with PHIV. And these once children are now transitioning into adolescence and adulthood, as many of us also are, and they're experiencing the same kind of problems and joys and things that we are experiencing, such as romantic relationships. They are starting to think about their fertility desires as they get older, but at the same time, they are also coping with a highly stigmatized disease and the issues associated with disclosure, required disclosure, and fear of transmission, and everything else that comes with having HIV as a young adult.
So we know that the biological and medical side of HIV has been well studied in the past 2 or 3 decades, but relatively little is known about the sociocultural aspects of HIV, which is what we're discussing now and in our whole symposium. So this unique group of almost 11,000 people growing up with HIV, little is known about their experiences and perspectives. So Hannah and I have decided to do fully qualitative research, which will focus on the perspectives and lived experiences of the participants, so of this unique, relatively small group of adolescents with PHIV.
So the way we looked at this, we used a semi-structured interview developed by Dr. Fair and Jamie Albright that asks open-ended questions about fertility desires and intentions, relationships, parenting, perceptions, provider interactions, and these participants' future goals. If you look on the right, you can see some sample questions. They are not really yes or no questions, they're very much have a discussion kind of questions. And so we used Atlas TI software to analyze this using grounded theory, which allows themes to emerge from the data instead of imposing themes on them. So it's a very kind of open-ended method of qualitative analysis.
Okay, now I'm going to talk a little bit more specifically about my study, which looks specifically within this group of about 11,000 adolescents with PHIV, looks specifically at Hispanic American adolescents living in the United States growing up with HIV, looking at their relationship and childbearing perspectives. So a little background on Hispanic sexual and reproductive health care, or health in general. We know that Hispanic Americans or Latino adolescents are disproportionately affected by PHIV. There's more rates of people who are Hispanic with PHIV than average population. And we also know that acculturation may influence sexual and reproductive health decisions. So that bubble on the top right is the definition of acculturation, which I talk about throughout this project. It's the process of adopting the cultural traits and social patterns of another group. So in this case, we're talking about immigration, Hispanic immigrants who come mostly from Central America and South America to the United States and are traditionally of the Hispanic culture, but now are trying to adopt or are adopting or have mostly grown up in America and are adopting to this English American culture. And the literature is really inconclusive about if this puts an adolescent more at risk for negative health outcomes, or if it's somehow a protective factor and spurs them on towards positive, healthy outcomes. So a few more of my specific methods. Apart from that study that developed by Dr. Fair and Jamie Albright, my participants also answered some questions on the VAS Acculturation scale for Hispanics, which asks a series of questions about one's English and Spanish fluency to try to develop. It really gives you a score of how Hispanic you are or how American you are. So I gave that to my participants. Overall, we had 15 Hispanic American adolescents, and they were interviewed by medical students in Southern California. Dr. Fair has a colleague in Southern California who we worked with. That's her. Her name is Leandra. I had the chance to meet her this year, and she's wonderful and conducted most of our interviews. Of the 15 participants, 10 were female, 5 were male, and the age range was 15 to 25. The median age was 19.8, so about 20. And they're from a pediatric infectious disease clinic. So, one moment. Overall, I have 3 different sections of results. This big chunk of results about their relationship, factors and perspectives, childbearing, and then this third unique piece about acculturation. So we're going to go through those now. So regarding relationships, they talked a good deal about disclosure and the difficulty of disclosure when you have this highly stigmatized and transmissible disease. It's difficult to tell another 15-year-old that you have that. But it is important to note that of the disclosure, a lot of the participants did talk about how they disclosed to a partner or a friend and only found a supportive and positive reaction from the friend. But then separately, to the second point is that some of them did not find a supportive response, but they were rejected. One 18-year-old male said, if they feel like they don't want HIV in their life, they'll probably reject you. I guess it's up to the person. It's pretty upsetting. And more than half of the participants had experienced rejection based on their HIV status at some point in their life. Transmission was also a big result. Worry and concern about vertical transmission. We talk about vertical transmission would be to your partner, and horizontal would be to your partner. Vertical is mother-to-child transmission to your child. And then the fourth piece we found regarding relationships is really unique. 5 of my 15 participants acknowledged that they were in an unhealthy or abusive relationship, but chose to stay in that relationship. One 20-year-old female said, he's always there for me, I don't want to end up by myself again. A beautiful thing about qualitative research is I know the whole story behind this. This woman's boyfriend is abusive and they have a child, and he neglects the child and is abusive and is addicted to drugs and tries to get the woman to be addicted to drugs. And she still decides to stay with him, and she doesn't say it explicitly, but it could relate to those factors at the top, disclosure and rejection. The fact that he does know she has HIV, and in a way he does accept her and still wants to be with her. So it could be fear, not wanting to seek another partner because of fear based on this underlying PHIV status. Regarding childbearing, 6 of my participants are parents, and 6 of the 7 pregnancies they experienced were unplanned. There's a high desire for pregnancy among this population, which is very important to note. 11 of 15 participants desired to have children in the future. And this is for a whole host of different reasons. One of the most interesting ones I thought was this 22-year-old female said, I want to have my own little family so I could tell my family bye. A lot of these participants come from a family where a parent has died, a lot of times because of HIV, or they're in foster care, or they're raised by grandparents or other family members, and don't have the best home lives. So starting the thought of having a new child so that you could start your own family is appealing for some. There's a varying knowledge of mother-to-child transmission. Only 3 of my 15 participants could state that the accurate rate of mother-to-child transmission. A lot of people, like this 16-year-old male said, I think it will be 100%. Did you say this? In reality, if you're strictly adhering to your medication, to your antiretroviral treatment, the risk of a mother passing HIV to her baby is 1%, less than 1%. And so this 18-year-old female who is a mom said, as soon as I got pregnant, I took all my medications. I've never missed a dose with him, so it was really low for him to get it. But like I said, only 3 of 15 participants could accurately state the risk of mother-to-child transmission. And overall, in this population, there's inconsistent contraceptive use. And then lastly, this piece on acculturation. This was very interesting to find. All 15 of my participants were acculturated to the English or American culture. You could think of it in either way. The questions center on English, but it's talking broadly about American culture. So this darker red circle is English or American culture. So 11 of them were bi-acculturated, so they're still fully acculturated to their Spanish, still fluently speak Spanish. And then 4 of them are only acculturated to the English and American culture, but none of them are only Spanish. So what does this mean for these adolescents and for public health? From this study, small study, we see that Hispanic young adults are engaging in romantic and sexual relationships at the same rate as that broader group of 11,000 adolescents with PHAV, but also at the same rate as the broader population of adolescents, of people who are 15 to 25. And they highly desire children, or think they will intend to have the children in future years. Contraceptive use is inconsistent. Many of the same things that we just found are true of the broader group, which is very important to know. We also see that language barriers do not explain gaps in HIV-related knowledge, but cultural expectations could put Hispanic adolescents at risk for interpersonal violence, like we touched on a little. Male-dominated relationships is a common trait of Hispanic culture, this thought of machismo, and limited sexual communication. This study was limited by its sample size. There's not a ton. This population is small, so it's difficult to recruit. Self-report and the lack of variability in acculturation of participants. It's very important. It's interesting to note that all 15 participants were acculturated to the American culture, but it could have been interesting if there had been wide variability and 5 were only acculturated to Spanish, a few were only both, and a few were only English, just to see if that changes their experiences at all. In conclusion, there's a definite need for culturally appropriate interventions. So for medical providers and social workers to know about this population, to know that acculturation can place an adolescent more at risk in some certain ways, and to go in knowing where they stand, and to challenge unhealthy gender-normed behaviors that leave young women vulnerable to poor outcomes. And similarly to that, interventions that could include mental health promotion and strategies to support and encourage healthy, intimate relationships. Kind of thinking about this healthcare as a holistic thing and not just focusing on keeping your viral load down or preventing transmission, to think about mental health and encouraging adolescents to pursue healthy relationships. And now Hannah will continue.
So I looked at more specifically those participants that in Mackenzie's study and another study, but all doing the same interview, that were parents, and looking at the intergenerational effect of HIV. So something that is really interesting about perinatally acquired HIV is that means that there is a whole family, multiple generations, that are affected by HIV. So in my study, even though none of the children, the babies, of the PHIV-infected parents had HIV themselves, they are still in an HIV-affected family. Also, these parents that I interviewed had a significant amount of childhood trauma, some of them did, because their parents had HIV, some of them died of AIDS, were very sick from AIDS when they were children, and that has an impact. And then also they had to grow up managing a difficult disease, a feared disease, a stigmatized disease, especially when they see the fear of their parent. It can have an impact on them. And this group, as we know from Dr. Frey's study, has really high childbearing intentions. So it's really important to understand how they parent and how they, what support they need in parenting and what they feel about parenting, because they do want to be parents. So this is kind of the overarching idea behind my study. It's well documented across the literature that traumatic childhood experiences greatly impact later parenting choices. So what happened to you with your parents greatly affects how you treat your child and how you raise your child. And so obviously in this PHIV family, this is going to be very important. So for my study, we had 11 participants. The mean age was 22, so older range, which makes sense because they're all parents. And it was recruited through physicians at PHIV clinics, adolescent PHIV clinics that are colleagues of Dr. Fair. And only 3 of my participants were raised by biological parents. It was pretty different across the board. Some were raised by foster families, some were adopted, some were raised by grandparents or aunts. And 10 of them were females, only 1 male, and 7 were Hispanic and 4 African American. And none of their children were infected. So this is kind of a little diagram showing how I did some of my coding. So as we talked about grounded theory, basically we let themes emerge from the data and we code based off that. So I had 4 main theme areas, just general parenting perspectives. So here they said it was important to be a caregiver, that they wanted to be a role model for their child, that they felt they needed stability in their life for their child. Some parenting rewards that we found, wanting to leave behind a legacy, having a family unit, and the lasting love that you get with the child. Some parenting concerns were stigma from other people because they have HIV, stigma towards their child, fear of transmission, and child behavior, which is a general one. And then there was also sources of support, the unique sources of support for these parents and how they are a little bit different than their peers. So for my findings, across the board we found that there were very normative findings for the most part. They were having the same problems that their peers are having that are uninfected, time management, that kind of thing. And then there were also HIV-specific findings, which I'll talk about in a minute. They do have very similar perspectives and experiences to their uninfected peers, which is important to note. This is because it is a manageable disease, because when you take medication, you're not really sick, you don't really have symptoms from HIV. They are just generally living their lives, kind of like their peers are. And then this unexpected theme, sources of support, and how kind of their medical experiences provide a secondary source of support. So actually, so now this is going to kind of go into the interactive part. So those of you that have pieces of paper, if you would look at them and see what the name is on your piece of paper. And I'm going to call out the name and then I'm going to ask you to read the quote. You don't have to read the little bio next to it. That's kind of just for your information. So first, who has Jessica? Will you read out her quote? I think the second one.
The second one?
Well, wait. No, the first one. Sorry.
That's when I think I want to go back. You know, when it's time for her to be in college, she'll be like, well, look at you, you didn't finish it.
Yeah, so this was pretty across the board that they had normative experience. They said a lot of things that you would expect any teen parent. A lot of them had to put their education on hold. They couldn't find a job because they were parenting. And a lot of them expressed that the importance of stability, which comes with having a job and having education, was really important. They also had very normative concerns, such as disciplining their child. A lot of them talked about how difficulties disciplining their child and difficulties planning for their child's future and how they were going to do that when they were so young themselves. They also cited normative rewards, that children provide happiness and that seeing the success of your child is, something that really is not paralleled in any other aspect of your life. And then they also had very normative sources of support in their family, their partner, their friends, along with the HIV-specific ones. So now we're going to go more into the HIV-specific findings. So if someone has Rosa, sorry.
But I do the right thing. I take care of myself. I try to keep myself undetectable and stuff like that.
Yeah, so Rosa is talking about something that is kind of what I thought of at first when I thought of parents with HIV, is that you have much more fear of getting sick. And so a lot of them did talk about how they were afraid of getting sick and not being able to be there for their child. And that a good part of being a parent with HIV is that you have to manage your illness. You have to take your medication. And undetectable refers to their viral load. And if you're undetectable, you generally don't have any symptoms. So that's just kind of an added burden and an added kind of thing that they have to think about that uninfected parents wouldn't. So whoever has Louisa, would you read the second one?
Yep. What makes a good parent? You're always in charge of the baby and always bring them to all the checkups.
Yeah, so this kind of goes back to when babies are born to HIV-infected moms, they have to go to a lot more doctor's appointments than babies that are born to uninfected moms, because they are taking a lot of medication to make sure that they don't get infected with HIV. And so that's just kind of think about all you have to do with an infant, and then these parents are having to do all these extra things to make sure that their infant doesn't have HIV. And so now we're going to move on. We're going to go to, does anyone have Lorena? Will you read hers?
I mean, I'm just worried in general, like, even though it's a low percent that the baby can get it, I still worry about that being 1 or 2% that my baby will get it.
Yeah. So this is kind of goes off what Mackenzie was talking about how they don't have a very good understanding of mother-to-child transmission. Even though when they're taking their medications correctly, it's less than 1%, almost everyone in my study cited that at some point they had a huge fear of transmission to their child. And so this is just an added stress, especially during pregnancy, when added stress can be very detrimental to your health. And the father that we interviewed really didn't have a clear concept of transmission, and so that's something else to consider. Would someone read Javier's?
It's been hard because she was living with me before I went to the hospital. When I went to the hospital, I had to get her to her mom. That was hard.
Yeah, so Javier was a participant that was really, really sick and in the hospital, and had a little girl. And this is kind of somebody that was experiencing HIV symptoms. He was our only participant that was experiencing HIV symptoms, so it's kind of a unique perspective of they recognize that this is a fear that they have, that they won't be able to be there for their child because they get sick with HIV. And while some of them, say that they don't think that'll ever happen, Javier was a really good example of how kind of the worst case scenario happens, and that providers have to be mindful that they could have fears about that. So now, some HIV-specific parenting rewards that they found. So does anyone have Jasmine?
Yep.
Yeah.
I always wanted a big family because it's that I lost my family and don't really know my family like that. I don't want to say a whole bunch of kids, but at least a good amount. So my family can keep going and I can have kids. It's something I can leave behind in this world.
Yeah, so this is something that was also found in Dr. Fair's Childbearing paper, that this population, because they lost their parents at a young age, in some cases, they do have this strong sense of the importance of leaving something behind, because they do kind of have an understanding of their future and mortality more so than others. And so this was pretty common across the board, that they wanted to create a family, especially if they had lost their family, and that they could create this legacy. And I think we have another one, Jessica. Does anyone have Jessica?
I haven't heard
Yeah.
in the second quote.
Yeah.
You have somebody that they're going to be there for you,
Yeah. So she was kind of talking about how, like Mackenzie mentioned, there is a lot of rejection of people with HIV, and so when you've gone through your life and been in relationships and been rejected, having a child is kind of this opportunity to always have someone that's going to care about you and love you. They won't care about your HIV status and these participants know that because they grew up with someone, like their mother had HIV, and they love their mother anyway, even though they had HIV, and so they kind of see this as a chance to get that acceptance and love that sometimes they don't believe they can get elsewhere. So we go into support. So does anyone have Gabriella? Sorry. Yay.
I didn't know where to go, so I just came over here, and they, social workers, helped me out looking for a shelter.
So this was the unexpected theme that we didn't really think about, and that I kind of went through coding and then thought to myself, there's something else going on here. There's something else good that comes out of having HIV when you're a child, which is shocking when you haven't spent forever looking at this data. But it's that when most of the time these participants come from marginalized groups, their uninfected friends don't necessarily have all this support. They don't have social workers that look out for them. They don't have nurses that are telling them, go back to school, you can do it, I believe in them. They don't have these doctors and these people that have known them for their entire lives saying that they will help them. They don't have someone to go to and say, I don't have anywhere to live, where can I live? And so the plus side of having PHIV, and kind of an unexpected part, was that these providers offer this immense support system for these PHIV individuals. And especially when they become parents, this becomes all the more important. And it becomes really important for providers to recognize that they have that important role in their lives. So thank you to everyone who read. I know we didn't get to all of them. I had some extra just in case. But I'm going to talk a little bit more about limitations. So like Mackenzie's, I had a small sample size. I only had 11. We also only used self-report, which means that we didn't go into any of the medical records or anything, so it was only what they told us. And then also that my results may not be generalizable. So based on how we recruited participants, we only recruited participants through providers. So therefore we recruited participants that were in care. So participants that have PHIV that are not in care may have very different experiences. But even so, there were some really interesting conclusions that we could come to. Basically, these participants, and one of them actually says this in it, they say, I want everyone to know that just because I have HIV doesn't mean that I can't do what normal people can, her words, not mine, that I can have a kid and that kid can be normal. And that was very reflected in the data. They are living their lives, they're facing the same kind of issues. But then on top of that, they have these HIV-specific issues, so things that everybody with HIV who has a kid would have to participate in, and then also these PHIV-specific issues, so the loss of a parent and that need to leave behind a legacy, and then also this immense support system that they have. The impact of childhood experiences, I really thought was going to be all negative, and when I first looked at it and came up with this hypothesis that childhood trauma from HIV would result in negative parenting perceptions, but the support provided by their social workers and their nurses and their doctors almost maybe counteracts this. This is qualitative research, so it's hard to say, but a lot of them talked about how, you know, they had people that were really supporting them and people that were role models for them when maybe they wouldn't have that in their families. And so it's really interesting and needs to be looked at more whether that support piece really does have a significant impact on how they parent their child. And so the only thing that I would say that would be the most important part coming out of this research is that providers need to know that they are a hugely important part of these individuals' lives. They do know this. I have worked with a lot of them. They know that they're important, but they continue to be important even after they leave their care, and that this support that the providers give often will trickle down into the child's development. And so because these parents, their child is not HIV positive, they won't have that same support system that these parents grew up with. And so it's really critical that with this new population that's having children, that it is recognized that their parenting skills and support and everything will impact their child's development. And providers need to be looking at how to enhance that and make it better so that everyone can be happy and grow up healthy and well-adjusted.